All right, today we're going to tackle the physiology of micturition. Now, I know this might seem like a super specific topic, but trust me, understanding it is absolutely critical whether you're prepping for exams or trying to figure out what's going on with a patient who has incontinence. So let's build a really solid framework for it together. So, have you ever found yourself just completely tangled up in that web of sympathetic, parasympathetic, and somatic nerves that control the bladder? Or maybe you get confused about which sphincter is doing what and when? Yeah, you are not alone. In the next few minutes, we're going to build a super simple, super clear framework to make sense of it all. So here's how we're going to break it down. First, we'll look at the hardware, the basic anatomy. Then we'll connect all the wiring, that's the neural control. After that, we'll see how the system runs its two main programs, storage and voiding. And finally, we'll wrap it all up with some key high-yield concepts to really nail it for your exams. All right, first up, let's talk about the hardware. You know, getting a solid handle on the anatomy of this vesicourethral unit is the foundation for absolutely everything that follows. Okay, this right here is the first major concept you've got to get. You have to stop thinking of the bladder and the urethra as two separate things. Functionally, they are one integrated unit, and this unit has two completely opposite jobs: to store urine safely at a low pressure, and then to get rid of it completely when you decide to. Mastering this dual function is really the key. So this image gives us a really nice bird's eye view, anatomically speaking. You can clearly see the bladder, which is pretty much just a muscular bag, and the urethra, which is the outlet pipe. Now, we're going to zoom in on the specific muscles that make this whole system work. Let's meet the main player in voiding, the detrusor muscle. This is the smooth muscle that makes up the wall of the bladder. And functionally, it's pretty cool. It acts as one single, powerful unit. When it contracts, the bladder empties. When it's relaxed, the bladder fills. It's really as simple as that. Okay, now let's talk about the gatekeepers, the urethral sphincters. First, you have the intrinsic sphincter, which is also called the rhabdosphincter. Think of this one as the workhorse. It has slow twitch fibers that maintain a constant tone, keeping the urethra shut when you're just at rest. Then you have the extrinsic sphincter, which is actually part of that big pelvic floor muscle group, the levator ani. This one's our emergency backup. It's got fast twitch fibers that jump into action to stop leaks during a sudden spike in abdominal pressure. You know, like when you cough or sneeze. Okay, so we've got our hardware all set up. Now it's time to connect the wiring. The neural control circuit is really where the magic happens, coordinating the bladder and those sphincters so they work in perfect harmony. Yeah, I know this diagram can look a little intimidating at first glance, right? But let's just simplify it. All you need to do is focus on the three main inputs going to this vesicular urethral unit: the sympathetic, the parasympathetic, and the somatic nervous systems. Each one has a very, very specific job, controlling that detrusor muscle and the urethral sphincters. Pay attention here, because this table is absolute gold for your exams. Let's walk through it. The sympathetic system is all about storage. It relaxes the bladder wall through beta-3 receptors, and it squeezes the bladder neck shut through alpha-1 receptors, basically keeping the gate closed. Then you have the parasympathetic system, which is for voiding. It contracts the bladder wall through muscarinic M3 receptors, squeezing the urine out. And finally, the somatic system, which comes via the pudendal nerve, gives us that conscious, voluntary control over the external sphincter. Look, if you walk away with just one thing about autonomic control, please let it be this: sympathetic is for storage, parasympathetic is for peeing. It's a simple little mnemonic, but it's going to save you so much confusion. All right, so with all that wiring in place, let's see how the system runs its first main program: safely storing urine. I mean, this is the state your bladder is in for most of the day, right? And this slide just lays it out so clearly, the complete opposition between the two states. During storage, which is kind of the default mode, the detrusor muscle has to be relaxed so the bladder can fill up, and the sphincters have to be clamped down tight to prevent any leaks. This is all run by the sympathetic nervous system. It's the total opposite of what happens when it's time to void. So how does the body pull this off? Well, the sympathetic system is working to keep that detrusor nice and relaxed, while at the same time, the bladder neck and the external sphincter stay shut. And the fundamental principle here, it's really simple. As long as the pressure inside your urethra is higher than the pressure inside your bladder, you will stay continent. That pressure gradient is the absolute key to successful storage. So as that bladder starts to fill up, stretch receptors in its wall begin firing off signals to your brain. And somewhere around 150 to 200 milliliters, you'll get that first sensation, that first little hint that, yeah, you might need to think about finding a restroom. Eventually. Okay, so once you get that signal, let's switch gears and run the second program, the voiding phase. This isn't passive, it's an active, coordinated reflex that completely flips the switch from storage mode to emptying mode.
All right, so you've made the conscious decision. It's time to go. What happens next is this really beautiful coordinated reflex. First, you voluntarily relax your pelvic floor and that external sphincter. That's like the green light signal that shoots up to the master controller in your brainstem, called the pontine micturition center, or PMC. The PMC then does two things at the exact same time. It cranks up the parasympathetic pathway, which causes a powerful contraction of the detrusor, and it shuts down the sympathetic pathway, causing the bladder neck to relax and open up. So now, with the bladder squeezing and the gates wide open, the bladder pressure skyrockets way past the urethral pressure, and you get efficient voiding. Okay, now that we have a solid handle on the normal physiology, let's connect it to the real world, to clinical medicine, and wrap up with the highest yield points. This is how you learn to troubleshoot the system when things go wrong.
You're going to see this a lot. A really common clinical problem is stress urinary incontinence, or SUI. This is basically when that storage mechanism fails under pressure. And by stress, we don't mean emotional stress, we mean physical stress, like from a cough, a sneeze, or even jumping. So what's actually going wrong here? What's the mechanical failure in SUI? Well, think of it like this. Normally, when you cough, that sudden increase in pressure gets transmitted equally to both your bladder and your urethra. It's like squeezing a balloon and the tube at the same time. The pressure difference stays the same, so nothing leaks. But in SUI, often because the pelvic support is weakened from something like childbirth, the urethra doesn't get that same pressure support. So the bladder pressure spikes, it briefly overpowers the urethral pressure, and a little bit of urine leaks out. Okay, let's quickly clear up a couple of things that students often get mixed up. First, the bladder neck. It's not a true, distinct muscle ring like you think of with other sphincters. The only reason it works like a sphincter is because it's absolutely packed with those sympathetic alpha receptors that tell it to contract. Second, always remember the division of labor. The intrinsic sphincter is for your day-to-day resting continence, and the extrinsic sphincter is your backup for stress continence. All right, time for the high-yield summary. This is the stuff you absolutely need to have locked in for your exams. Remember, storage is a sympathetic job, voiding is a parasympathetic job. Continence is just a game of pressures. Urethral pressure has to be greater than bladder pressure. Know the key volumes, 150 to 200 ml for that first sensation and a full capacity of about 400 to 600 ml. And finally, don't forget the boss coordinating the whole show from the brainstem, the pontine micturition center, or PMC. And I'll leave you with a little clinical thought experiment to really solidify this stuff. Based on everything we just talked about, what do you think would happen if you gave a patient a drug that blocked alpha receptors? Or what about one that stimulated beta receptors? Think about it. Would that mess with storage, or would it mess with voiding? This is exactly how you connect the dots from basic physiology to pharmacology and taking care of patients. Thanks so much for watching.